do want to welcome you to today's briefing and thank you all for joining. Intensifying effects of climate change are seen in human, community, and ecological health, often affecting vulnerable communities disproportionately. In addition, they put added strain on medical, public health, and social services systems. Today's discussion is based on insights from articles published in our May issue on climate, health, and equity, which we published just this past Monday, May 4. And papers in the issue highlight the costs of climate change on health and human systems and offer solutions and models from individuals, communities, and policy level actions. Before we start, I do want to note that we are very grateful to our theme issue advisors, Drs. Cecilia Sorensen and Sakobi Wilson, both of whom are participating today. Really great, again, deeply appreciative of all of their efforts. And we're also deeply appreciative of the Kresge Foundation and the Robert Wood Johnson Foundation for their support of our work. We couldn't do it without them, so very, very grateful. Also want to thank all of our presenters and those in the audience. Really appreciate everybody's interest and participation. We do have a lot to cover with several panels, so I just want to jump in here. There will be time for questions in each session, and you can submit those through the Q&A tab at the bottom of the screen. You don't have to wait until the Q&A period begins to type in questions. You can just enter them in the chat at any time during the session, so we hope you'll feel free to participate. And let me now introduce Cecilia Sorensen. Again, she was one of our advisors. She is director of the Global Consortium on Climate and Health Education at Columbia University. She will moderate our opening roundtable, Addressing Climate Through Policy and Intervention. Cecilia?
Thank you so much. It's such a pleasure to be here today. I'm so excited about the launch of this special issue. We put so much energy into making this a really successful production, and today is just a celebration of that. So our first roundtable will be talking about addressing climate through policy and intervention. We will be hearing from several different speakers. The first will be Dr. Stefan Wheat, who is an emergency physician and assistant professor of emergency medicine at the University of Washington School of Medicine, followed by Dr. Carlos Gould, who is assistant professor at the University of California, San Diego, School of Public Health and Longevity Science. This will be followed by a presentation by Dr. Chris Boyer, who is a researcher at the Center for Health and the Global Environment at the University of Washington. Then we will hear from Lisa Clemens Cope, a senior research fellow in the Health Policy Division at the Urban Institute. And last but not least, we'll hear from Elise Moore, who is a postdoctoral associate at Cornell University. Following this panel, we will have about 20 minutes for Q&A, so I encourage you to put any questions you have for our panelists into the Q&A. And with that, I'll turn it over to Dr. Wheat. Thank you.
Thank you so much, Dr. Sorensen. And on behalf of myself and all my co-authors, I want to say a thank you to Health Affairs for organizing this special issue and this event. I also want to say a big thank you to all my co-authors for making this work possible. So I want to start with an essential tension here. The reality is that the US healthcare system is both contributing to climate change through its greenhouse gas emissions while also treating its consequences every day. We generate about 8.5% of the total greenhouse gas emissions in the US. And at the same time, we're seeing more heat-related illness, more wildfire-driven respiratory disease, and care disruptions after extreme weather events. So we're fueling the problem while also trying to manage the fallout. And our paper asks a simple question. What would it look like to actually align health policy with climate action? We wanted to provide a review of evidence for prominent policy levers for making health systems more sustainable and more resilient. And I think what we found is pretty promising because many of the same strategies that reduce emissions also improve care and promote resilience. Because that's what I think we're really aiming for: better quality, lower cost, and more resilient health systems. We organize the policy solutions in our paper across 3 levels. Macro level strategies target payers, insurers, and policymakers through levers such as reimbursement reform, national decarbonization standards, and regulatory frameworks. Meso level actions focus on health system administrators and public health agencies, emphasizing institutional operations, sustainable procurement, and resilience planning. And finally, micro level interventions engage individual health professionals and community organizers to integrate climate considerations into clinical care, education, and local preparedness efforts. Next slide. So first, the policy and payment, or our macro lens. And as it stands in the US, the prevailing model is to pay for volume, more tests, more procedures, more utilization. And that drives waste as well as emissions. But when we shift to a value-based care model, something interesting happens. We reduce low-value care, we improve care coordination, and emissions go down as a byproduct. So decarbonization isn't separate from quality, it's aligned with it. There's also a clear financial case. Our paper outlines how efficiency and energy improvements alone can result in significant healthcare cost savings. But we're missing a critical piece, and that's measurement. Most hospital systems in the US don't consistently track or report emissions. And if you don't measure it, you can't improve it. Other systems like the UK's NHS have shown that mandatory carbon reporting drives real progress. Meanwhile, in the US, we're still relying mostly on voluntary efforts, and that's really just not cutting it anymore. Second is the health system operations, or our meso lens. And here's where the majority of our emissions actually come from. Over 60% is just in the supply chain alone. So what we buy in healthcare really matters. This creates a major opportunity around procurement, choosing lower emission products, requiring vendors to disclose their emissions, using our purchasing power to shift the market. We also highlight the idea of a circular economy, which really just means stop treating everything as disposable. There's strong evidence that reusing devices, reducing waste, and redesigning supply chains can cut emissions and save money without compromising safety, all while improving resilience to climate hazards. And that brings me to resilience. Climate impacts are already disrupting care delivery. We've seen supply chain failures, medication shortages, hospitals strained by extreme events. So we need systems that can adapt with early warning systems, climate-informed emergency planning, and infrastructure that can withstand shocks. And this is about keeping care going really when it matters most. Third is the clinical front line, or our micro lens. And the key to this is really that none of this works without people. We need a climate-ready workforce. Clinicians who can recognize climate-related health risks, adapt care during heat waves or wildfire smoke, and talk with patients about these risks. Right now, training is uneven, but there's definitely growth. So what's the big takeaway? Decarbonization and resilience are not competing priorities. They reinforce each other. And this isn't just about sustainability. It's about how we define high quality care. If we align policy, systems, and frontline practice, we reduce waste, we lower costs, we improve outcomes, and we build a system that can withstand what's coming as a result of climate change. But right now, efforts are fragmented. Next slide. So the next step is clear. In order to enable those health systems of the future to thrive in the setting of climate hazards, and in order to uphold our oath to do no harm, we need to embed sustainability into the core of healthcare, into payment models, into accreditation, into what we measure and report. Because ultimately, this is not just a climate issue. It's an opportunity to design a health system that delivers better care for our patients today and into the future. Thank you so much for giving us the opportunity to share a little bit about our article. We hope that it serves an enticing primer for folks to dive in and learn a little bit more about these issues. And with that, I'll pass it on to our next speaker, Dr. Carlos Gould.
Thanks, Stefan. So I'm presenting work joint with Anshit So at the California Health Benefits Review Program and with Shiv Pugliati and Sarah McMenamin at UCSD. Here we argue that health insurance, through short-term, automatically triggered changes to coverage, payment, and network policy, is one of the most practical tools the US already has for adapting to climate change, and it's currently underused. So in this 5 minutes, I want to make 3 points. First is that climate policy misses most of the health damages from climate change. I want to tell you how a simple framework can adjust that gap, and that authorities to act largely already exist. Click. So the scale of our challenge is large. Heat, wildfire, smoke, and flooding currently account for about 140,000 excess deaths each year. Click. Total healthcare-related costs from climate change run on the order of about $100 to $200 billion each year. Yet, 0 federal major disaster declarations have ever been issued for an extreme heat event, not even for the 2021 Pacific Northwest heat wave, which killed close to 1,000 people in just a single week. Health insurance has tools to respond. Early refills, network flexibilities, out-of-network payment parity. So we do recognize that under certain circumstances, health insurance needs to help us cope and respond. The problem, click, is that they activate only when a president declares a major disaster. And so even for events that do get declarations, like hurricanes, excess mortality persists years after the declaration window closes and flexibilities subsequently expire. Going to the next slide. And that's the central problem that we see. We have a policy system designed for exceptional disasters, but most climate-related health burdens are day to day. Thinking about heat waves or cold snaps that roll through every summer and winter, regular wildfire smoke incursions, or routine flooding that disrupts our care. So our framework takes the relationship between climate hazards, environmental exposures, their health impacts, and healthcare-related costs and seeks to interrupt them in two ways. Pathway 1 acts upstream to reduce exposures to environmental hazards before they damage health. So we're thinking about covering things like air conditioning, air filtration, and post-flood remediation. Pathway 2 acts a bit more downstream, trying to prevent the hazard from worsening public health. So here we're focusing on how health insurance can preserve access to care and prevent impacts from compounding. So we think about things like flexibilities around prescription refills, out-of-network care at in-network rates, or enhanced telehealth options. So to give an example, consider a National Weather Service heat advisory that's posted for a region in a certain time window. That trigger can activate the coverage of air conditioning units or transport to cooling centers or even work with utilities to ensure that people can pay to run their air conditioners. It also opens the possibility then of early prescription refills, telehealth options, or proactive dialysis scheduling for on the care side. These are things that we think that can help people stay safe from extreme heat and maintain their quality healthcare needs. And this same kind of logic extends across a range of climate sensitive hazards. If you can go to the next slide. Smoke drives respiratory harms, so we can think about air quality indices or smoke forecasts, which are getting better and better, that can trigger the coverage of air purifiers or HEPA filters. Flooding creates regular mold and infectious disease risks, and re-entry orders can activate remediation benefits or network flexibilities. Power outages can sometimes be posted in advance, and if those threaten insulin or medical device users, we can work to recognize public safety power shutoffs to activate supports. Moving to the next slide, the evidence base for this kind of design is honestly developing, and it's mostly a little bit tangential. So we've seen evidence from Mexico and Colombia that expanding health insurance coverage does reduce cold-related mortality. We've also seen proactive dialysis protocols and pharmacy waivers that have demonstrated reductions during climate-sensitive events. But there's largely no prospective evaluation of this kind of insurance-based intervention. Yet I think that they're well designed to generate really good evidence. They'll be geographically bounded, they'll be automatic based on public thresholds that create natural variation in coverage, and claims data can track utilization and outcomes in ways that most studies can't. From the insurer perspective, we see the economic logic that climate hazards generate very expensive ER visits, very expensive hospital admissions. And so covering things upstream, like air conditioning or air purifying, might be a way to substitute for those downstream costs. And we see in our literature review that authorities exist to act. So we have Medicaid 1115 demonstrations are already used to alter home environments. Medicare Advantage plans can incorporate trigger-based rules under current coverage. Section 1135 waivers have shown that federal coverage rules can change rapidly, even within days. So in closing, I think that we all can see that adapting to climate change is a major priority, but I'm not sure that it's going to be inevitable. I think we will have to design our society and our healthcare systems in a way that can help us reduce those risks. And in this article, we show how health insurance can help. It's not going to substitute for good housing policy. It's not going to substitute for energy infrastructure. It'll never be able to substitute for good quality healthcare. It won't be able to substitute for climate mitigation. But the tools do exist. They are available now, and I think the case is straightforward for using them. So thank you for your time, and I'm going to pass it off to Kartikeya Batotia.
Thank you. Thank you to the Health Affairs team and my panelists for this opportunity. My name is Kartikeya. I'm a research fellow at Harvard. presenting our policy insight on the distribution of heat-related health costs. I'm here on behalf of my co-authors, all of whom are at Harvard as well, except one who's at the Euro-Mediterranean Center on Climate Change. So I'm going to use my 5 minutes to walk through the argument of the paper rather than just the slides. There's a lot of ground to cover, so I'll be speaking beyond what's on the screen. Our starting point is that extreme heat is no longer an episodic hazard. It's a structural economy-wide risk, though it is rarely treated as one. In this paper, we use extreme heat as an umbrella term encompassing both acute heat events and chronic heat exposure because the economic consequences operate across both timescales. So heat-related costs are rising. As you can see on the screen, recent estimates place annual heat-related deaths globally above 500,000. In the US, age-adjusted mortality rates have climbed nearly 17% since 2016, and an adaptation gap is much more magnitudes more than the current flows. So these figures are well established, but what they do not tell us is who actually absorbs these costs. Is it a worker who loses wages, or is it a household that borrows to cover cooling or medical bills, or is it a firm that raises prices in response to heat shocks? Or whether it's the government that diverts emergency funds. The literature as of yet does not give satisfactory answers to these questions, and our paper talks about that in detail. Next slide, please. Our paper identifies three dimensions that are underexplored. First is who is hit first, how are the initial health burdens and economic costs distributed across people, firms, and governments. Second, how do these costs travel? For example, when a business faces higher cooling expenses or reduced output, these costs are passed on through prices, wages, or employment decisions. And understanding that transmission is critical. And the third, the health question at the center of this work. What does it ultimately mean for health and longevity when these costs accumulate in households that are already disadvantaged? Next slide, please. So we map 5 categories of economic actors who bear heat-related costs: workers, households, firms, governments, and other stakeholders. Now, heat researchers have typically distinguished costs across sectors or demographic groups. For example, the differential impact on gender is somewhat studied, or on high versus low-income populations. And although these framings are useful for directing resources towards highly exposed sectors or identifying inequalities, they offer minimal insight into the ways in which costs are transferred between economic actors. So that is the contribution of our policy insight. The key message being that costs cascade. When a firm's output falls, it may cut wages or raise prices. When government revenue declines, safety net programs shrink. In each case, the burden flows downward, and the most disadvantaged households are least equipped to absorb it. Next slide, please. So we reviewed the major analytical approaches in these space, and since this is a very technical discussion, I won't expound a lot on this, and I can speak in more detail during Q&A. But these are macroeconomic modeling, physiological models, survey, and quasi-experimental approaches. Each contributes important evidence, but we identified 4 systemic blind spots across all of them. Informal adaptation, this could be unpaid labor, caregiving, time reallocation goes uncounted. Heat-related health spending is rarely linked to broader economic damages. Opportunity costs are missing entirely, that is foregone income and investment. And most critically, none of these methods adequately trace how costs pass through from one actor to another. Next slide, please. So we propose 3 priorities for the field. First, better data. Economists need improved measures of impact of heat on productivity across climate and sectors, and reduce barriers to acquiring firm-level data on prices, wages, and profits, and access to household financial information on adaptation and health spending. Second is something that feeds into the data, that is standardized metrics for measuring cost distribution. For example, the share of productivity losses borne by labor versus capital, or the degree to which heat-induced production shocks pass through to wages and prices. And third, benefit cost analysis applied to heat interventions with distributional equity built in. Such analysis integrate and synthesize information from the various approaches I described on the previous slide and Recent methodological advances allow us to incorporate equity considerations, but heat-related interventions have received very little attention in this regard so far. So the next phase of research in extreme heat must continue to be collaborative, linking economists, climate scientists, public health researchers with implementation agencies. Such collaborations exist, but they are especially important where formal legal and regulatory protections for workers and communities remain limited or even absent. Building on existing policy processes, this could be occupational heat standards, heat action plans, or climate adaptation strategies, would help translate causal evidence into enforceable standards. Next slide, please. And I want to close the presentation with the very objective of why we wrote this paper. Better identification of who incurs costs is essential for governance and accountability. Although costs of heat are widely dispersed, the capacity to finance and implement adaptation remains highly concentrated. National governments, international donors, and large private sector actors often control the expertise, funding, and decision-making authority that shape adaptation priorities, and a mismatch between where the losses occur and where the decision-making power lies impairs responsiveness at the community level. And thank you. I will pass the mic to Dr. Boyer now.
Great, thank you so much, and greetings from Rarotonga, Cook Islands, hence my tropical and very windy background. But thank you to Health Affairs and the panel for being a part of, or allowing us to be a part of this event, and very excited to talk through our study assessing the implementation of climate and health adaptation in Pacific Islands. So to start, Pacific Island jurisdictions encompass 22 countries, territories, and areas, and we also included the state of Hawaii that spread across the Pacific Ocean and face several climate change and health risks. The figure here from the national assessment, or the fifth national assessment, U.S. National Climate Assessment, illustrates the diversity of some of these climate impacts affecting Pacific Islands, most of which have resulting effects on population health, some more directly, like extreme weather events such as heat waves, wildfires, floods, tropical cyclones, others more indirectly, such as emerging infectious diseases, impacts on food security, water availability, and water quality. Next slide. And at the same time that we are better understanding the health impacts of climate change in these communities, there's growing evidence base of potential adaptation options. And this includes specific interventions like risk assessments, trainings for healthcare workers, as well as national policies and plans that are focused on climate change and health adaptation, and as well as guidance on building climate resilient health systems from partners such as WHO or the US CDC. Yet in the Pacific and globally, there's still difficulties in bringing this evidence into public health practice in many jurisdictions, including effectively delivering these interventions and supporting integration of climate risks into health planning and decision-making, leaving us with this implementation gap for climate change and health adaptation, which is what our study was hoping to further unpack. Next slide. So for the study, we aim to synthesize the determinants and the stage of implementation of climate change and health adaptation activities in Pacific Island jurisdictions. We conducted a qualitative analysis to explore emerging themes related to health adaptation implementation across these jurisdictions and across sectors, including assessing the level of implementation and barriers and facilitators to implementation. So between June 2024 and July 2025, 18 key informant interviews and 5 focus group discussions were conducted with health and non-health sector stakeholders from 14 different Pacific Island jurisdictions, which I've included here on the map to see some of the spread of the geographic scope of the study. A total of 33 participants were involved. Our health participants were representatives mostly from the environmental health units, as well as the public health emergency preparedness departments. The non-health participants were representatives from ministries or departments of environment or climate change, national disaster management offices, and Met services. Next slide. So to assess the level of health adaptation implementation, we developed the typology of health sector adaptation steps and associated criteria. So the 7 steps here are aligned in this matrix. For each step, we developed criteria for 4 levels, including low, medium, high, and very high. And the end result was a collection of ratings and the rationale behind those ratings, 1 to 4, across the 7 health adaptation steps for each jurisdiction. And this was based on the qualitative data that that we collected. Next slide. So the heat map here summarizes the implementation level by percentage of jurisdiction that recorded that rating. So some of the key takeaways I want to highlight here are that steps 1 through 3 recorded the high percentage of low and medium ratings. Step 2, which was engaging and building partnerships for climate change and health, skewed the most toward medium and high ratings, which I've highlighted here. And steps 1 and 2 received over 20% of high ratings. Additionally, step 4, which is developing a climate change and health adaptation plan, had the most variance across all the steps, receiving ratings across all levels from no activity in a jurisdiction to very high activity. Sorry, next slide. And just to continue, step 5, operationalizing the adaptation plan had high percentage of low and medium ratings as well, and no jurisdictions recorded no activities for this step, which indicates to us that jurisdictions were still moving forward with the operationalization of interventions, even if policies and plans were not necessarily in place to guide that implementation. And then lastly, steps 6 and 7, which focus on monitoring and evaluation, review, and learning to improve the quality of interventions, again highlighted here, received the highest percentage of no activity or low activity ratings. And just a note, in the actual paper, this will be an interactive figure that you will be able to click on and see the rationale across the different stages and steps. Next slide. So just to end here, I also wanted to summarize some of the emerging barriers and facilitators that were identified during the analysis, which can help inform actions to transition from pre-implementation to full implementation. So in terms of barriers, we found that climate health often is not seen as a high priority for public health agencies. For local conditions, we found that they produce highly challenging implementation environments in Pacific Island jurisdictions, including logistical challenges in reaching geographically isolated populations. The lack of sustainable funding highlights the need for updated, flexible financing modalities for climate and health that reflect more the implementation realities on the ground. And then for where climate and health is situated within the government structure plays a significant role in implementation. So many jurisdictions had no dedicated climate change and health program, or also lacked the mandate from the public health agency to actually lead on climate change and health adaptation implementation. In terms of facilitators, access to contextually specific climate and health data can help build awareness and buy-in, particularly from communities and decision makers. Beyond the formal coordination mechanisms that exist, we found that cultivating more informal relationships across units and departments and agencies really helped facilitate more effective implementation in the eyes of our participants. There's a growing visibility of climate and health impacts, especially extreme weather events in many jurisdictions, that creates this sense of urgency and tension for action that is needed to build resilience and health sector and can lead to more advanced implementation. And then lastly, we know that climate change is often coordinated by non-health agencies, making the outside partnerships vital for any health adaptation implementation. So just to finish on a final thought, overall, a robust foundation for health adaptation exists in Pacific Island jurisdictions. This is bolstered by strong intergovernmental relationships, high social capital, and longstanding regional partnerships. Investment and resources have tended to focus on early stages of implementation, but there's a need to shift more towards actually how we operationalize these plans or make use of this evidence. And jurisdictions are more advanced in health adaptation steps, such as establishing coordination mechanisms, building awareness, and conducting baseline risk assessments. But there's a lack of maturity in actual implementation of interventions, and particularly around monitoring, evaluation, and learning to improve the quality of interventions. So thank you so much for the time. These is recognize my colleagues here that were part of the study, as well as the funding and ethics acknowledgement. So thanks so much, and I will pass over to Dr. Clemens Cope.
Hi, I'm Lisa Clemens Cope. I'm a senior fellow at the Urban Institute. Today I'm sharing findings from our study examining outdoor work and climate exposure in the US with my co-authors Lisa Dubé, Vincent Pansini, and Avani Pugajendi, with support from the Robert Wood Johnson Foundation. Next slide, please. About 1 in 5 US workers, 22% of the workforce, works outside. Most prior research has focused narrowly on heat alone or a single industry. We wanted a fuller picture, so we linked workers' demographics, benefits, and health to their climate-related exposures, and the stakes are high. A study by Alamad and others last year found that the odds of workplace injury increased from a heat index of just 85 degrees, and the risks were smaller in states with occupational heat rules, sorry. And wildfire smoke compounds the picture. Its particulate matter is more toxic than other pollution sources. Federal air quality protections for workers provide voluntary guidance only. Next slide, please. So outdoor workers look demographically distinct from indoor workers. They're overwhelmingly male. Hispanic adults make up nearly 27% of the outdoor workforce versus, next slide, please, versus 17% of indoor workers. That's right. Educational attainment is lower and household income skew lower. What this means in practical terms is that the outdoor workforce is concentrated in groups that generally have less bargaining power in the labor market, which becomes important when we start talking about who can actually refuse a hazardous shift. Next slide, please. Now to the protections, or more accurately, the gaps. Outdoor workers are twice as likely to be uninsured, 16% compared with 8% of indoor workers. They're also nearly twice as likely to be self-employed, 16% versus 9%, which often means no traditional workplace protections at all, and they had much lower rates of paid sick leave. One bright spot, union coverage is somewhat higher among outdoor workers, 17% versus 11%. But taken together, the picture is one of substantial exposure to climate-sensitive hazards paired with thinner benefit protections, a combination that can deepen financial strain when illness or injury occurs. Next slide, please. So overall, outdoor workers look healthier. They report lower rates of anxiety and depression compared with indoor workers, and nearly half report no chronic conditions at all. But this is almost certainly in part of the healthy worker effect. Workers who develop chronic conditions may quit in outdoor jobs, leaving us with a sample biased towards those who are still well enough to be out there. The acute injury picture tells a different story. Outdoor workers were more than twice as likely to report a work-related injury in the past 3 months, 2.8% versus 1.1%. And prior research also documents elevated suicide risk in construction and substantial post-traumatic stress and depression among emergency responders after disasters. So serious mental health concerns remain very much on the table. Next slide, please. So what do we do? A coherent response spans federal, state, and local action. First, set a federal floor. OSHA's proposed heat rule, still not final, could establish enforceable national standards for acclimatization, water, shade, and rest breaks while preserving local authority to go further. Second, extend standards beyond heat. Only 3 states have wildfire smoke rules with air quality triggers and required protections. There is no federal counterpart. Third, unlock some emergency funding. Recognizing extreme heat as a major disaster under the Stafford Act could open up FEMA assistance for communities to do better to support affected workers. Fourth, strengthen the economic safety net, paid sick leave, and clearer work compensation pathways for heat and smoke-related illness may reduce the incentive to work through unsafe conditions. And fifth, reach the workers most at risk through required multilingual pre-season training, real-time surveillance of heat and air quality exposures, and targeted inspections. We hope you will read the full paper in Health Affairs. There's so much more there. Thank you. And now I'll pass the mic to Dr. Moore.
Hello, everyone. It's a pleasure to be here today, and thank you for the opportunity to share about our work. And thank you to Health Affairs for organizing and to everyone for joining. My name is Elsie Moore, and I'm presenting on behalf of myself and my co-authors on our study titled Menu Changes Under New York City's Revised Food Standards Were Associated with a Reduction in Greenhouse Gas Emissions. Next slide, please. To begin, I just want to briefly ground us in the motivation for this work. And that is that food systems are a major contributor to global climate change, and they account for approximately 30% of global greenhouse gas emissions. And there's been a growing interest on the role of public institutions and food procurement and service policies and how they can play a role in reducing greenhouse gas emissions. Our manuscript focuses on the New York City food standards for meals and snacks purchased and served, which I will call the standards. And these standards apply to any government facility that purchases or serves food. And collectively, it covers approximately 219 million meals and snacks each year. The food standards are revised to reflect the most up-to-date nutrition evidence every 3 years. And in 2022, the revisions were notable in that they explicitly elevated the interrelated goals of promoting individual, community, and environmental health through requirements aimed around reducing greenhouse gas emissions and addressing diet-related diseases. Next slide, please. So for our final analytical sample, it consisted of 4 agencies, which together accounted for approximately 77% of all meals and snacks served in New York City in 2023. We used menus from fiscal years 2019 through fiscal years 2024 and excluded fiscal year 2020 due to COVID-19 service-related disruptions. And we used 2 related analytical approaches in this paper. First, we examined the change in the center of the plate entree offerings for all submitted menus for the fiscal years. And we categorized the entrees according to their primary protein source: chicken, beef, turkey, pork, seafood, or vegetarian categories. So that sample menu that I show on the screen, as an example, that would be roast chicken thigh was categorized as chicken. Second, we assessed the greenhouse gas emissions and the nutritional content of 7 consecutive days of total menu offerings. So that included entrees, side dishes, and beverages. So in the sample menu, that would have included all of the items as a part of it. And we used existing nutrition and greenhouse gas emissions databases to compare estimates before and after the 2022 revisions to the food standards. Next slide. So I want to highlight a couple of the key results. Next slide. So on this slide, I'm showing the center of the plate analysis results. So on the y-axis are the protein categories, and on the x-axis is the percentage point change between fiscal year 2019 and fiscal year 2024. And each bar and its color represents a program or an agency. I'm going to highlight 2 pieces of this. So on the top of the figure in the red box, I've highlighted across all agencies that the frequency of beef offerings declined between the fiscal years. And in the middle, highlighted in the red box, showing that the frequency of vegetarian offerings increased between fiscal year 2019 and fiscal year 2024. Next slide, please. So on this slide, I'm showing a table of the daily greenhouse gas emissions associated with total menu offerings before and after the revisions to the standards. And at the top, I'm highlighting in the red box for all agencies and programs combined in our sample. And across these, greenhouse gas emissions for total menu offerings decreased by 21% per portion, or 22% per 1,000 calories. We also observed significant reductions for many agencies and programs. Next slide. So this table looks a similar setup, but it shows the nutritional content of meals associated with total menu offerings. Again, the red box highlights all agencies and programs combined, and we found that there was no statistically significant change in overall nutrition following the 2022 revisions for all agencies and programs combined. However, some individual agencies and programs did experience statistically significant changes. Next slide. So in summary, the menu offerings provided under the 2022 revisions were associated with a reduction in greenhouse gas emissions while maintaining nutritional quality. Next slide. And thank you so much, and I will pass it back to Dr. Cecilia Sorensen.
Thank you so much. What an incredible panel. I mean, the diversity of different publications represented here, and just is so exciting to see how much the literature is expanding around climate and health equity. For those of you who have questions for our panel, we welcome you to put them in the Q&A and we'll get started. We have about 20 minutes. So I'm sort of fascinated, so Dr. Batosha, you're talking about how health costs are rising related to heat, but you could sort of expand that to almost any climate exposure, and saying who is really bearing the cost of this? Because there's all these invisible payers, right? And we often talk in terms of disability adjusted life years, and but who's really paying? And then Dr. Clemens Cope, you're thinking here about employers, outdoor workers. Dr. Gould, you're talking about insurance companies, and Dr. Wheat, you're talking about healthcare systems and patients, and these are some of the payers or those who are being impacted. So my question for you is, do these impacted communities, being, employers, outdoor workers, health insurance companies, and health systems, do they know that they're paying, in your experience? Yes or no? If not, what barriers? What are the barriers to reach these audiences? Are these data challenges? Are these communication challenges? And how might we improve our communication? So it's kind of a three-part question, but really building on this idea of who is paying for this and how can we improve the invisibility of the costs. And I open the floor to anybody thinking about the different populations that you are studying or working with.
Uh, I can begin at least from our research. We know that people are, from just a household POV, a household can see that their utility bill went up by certain number of dollars, and they can also see that during heat waves, groceries tend to cost more. We have emerging evidence from across the world that heat waves are a better predictor of food inflation than even
Mm,
sometimes monsoons. So the causal chain might be hidden, but price increases don't come with labels, and so a lot of the transmission is indirect. And to answer the question about communication. No, and that's a part of the problem that a lot of the costs are just hidden, and people are unaware, and
mm,
it's only obvious in hindsight when you map the system in
mm.
time of a household facing financial strain sees a dozen different pressures from everywhere: rent, food, utilities, medical bills, and heat is just one contributor among many.
Yeah, fascinating. Stefan, go ahead.
Yeah, thanks, Cece. I was just going to add, from our perspective, and we addressed this a little bit in the micro lens portion of our piece. Um, some of this is addressed, but otherwise, the what I think is recognized from a clinician to patient interaction level. The majority of our patients, I think, do recognize that climate change is real, but I don't think that they, for the most part, recognize that it's an issue that's impacting their health
Mm,
already. And on the other side of that conversation, most health professionals actually do recognize that climate change is actively a healthcare issue and it's impacting their patients, and they feel a responsibility to communicate that
mm.
risk to their patients. And so that's why we delve into the kind of the healthcare workforce preparedness piece in that micro lens portion of our paper, because having that conversation and being able to be an authority with your patient around this issue and help them make that connection between climate change and health is an important piece of the puzzle.
Absolutely. And in your experience, Dr. Wheat, do healthcare systems understand that they're paying some of this?
I think increasingly so. I can't speak for all healthcare systems, but my own healthcare system increasingly is recognizing that there is
Mm,
a resilience cost when we don't account for healthcare or climate hazards, both in our region and elsewhere in the country. But there's also we're leaving money on the table when we're not addressing sustainability issues as well. So if we're
mm.
not, finding ways to be more sustainable in the care we provide, we're leaving money on the table. So yeah, I think it is something that healthcare systems are increasingly recognizing.
Yeah, thank you. Over to Dr. Gould, and then we'll go to you, Dr. Clemens.
Yeah, it's a good question. And I think some things are very salient. I think it depends very much on the hazard.
Mm,
And of course, climate change attribution science is complicated in the way in which we attribute damages to health is complicated, but heat waves accumulate, excess ED visits and hospital admissions and deaths very quickly.
yeah,
So that's, I think, on the more obvious side. But then there are things that are much trickier. So we know that there's a very large burden of disease from cold days, but those accumulate over the course of weeks. And those I think are less obvious. Similarly, you might think about increased infection-related risks that happen from routine floods over the course of weeks or even months when you're thinking about hurricane impacts. I think those things are much less obvious. And so when we're thinking about what people see and what they know they're bearing the cost of, I think it depends a lot, and we can't think about climate change as a monolith. But from the perspective of thinking about insurance companies are very smart and they're very highly motivated to be thinking about costs. And I think we're
yeah,
seeing much quicker movement on the property insurance side.
yeah.
So I suspect that health insurance companies will increasingly realize this. And we've seen, again, these movements that exist within the US. And in our article, we offer a bunch of examples, both domestically and internationally. So there are changes.
Yeah, it's coming, right? And thinking about what's the return on investment, right, for these entities who are responsible. Over to you, Dr. Clemens.
I agree. The health insurance is the costs are borne by them, but also the cost is borne also by vulnerable outdoor workers. Like as we found, their uninsured rate is twice as high, so they are bearing the cost themselves. So I think we can't let lose sight of the fact that a lot of people are bearing the cost themselves in money and health.
And Dr. Boyer, just, you sort of bring in this perspective of working with governments and working with a lot of stakeholders. Are governments seeing this, at least where you're working, that they're bearing sort of this invisible cost of climate?
Yeah, I think to an extent, though, I think as I highlighted in, when we started to unpack some of the barriers of why there's not more action on the climate and health adaptation side, we did keep coming back to this idea of like how things are prioritized within governments. And oftentimes, like in most governments, health often gets brought down because maybe those connections are not being linked to how much it's costing the health system, how much it's costing the populations, how much it's costing the health workforce, which is most of the perspectives that we gained from our study. So I think connecting those dots is that, to your point around like communication issues and things like that, is very important because at least in the Pacific context, climate change is a high priority, but health is often not brought into the table of that. So trying to make sure that they're at the table and these costs that eventually that are going to be already happening and increasing in time are discussed and brought as evidence to for more climate action generally and globally. So
Mhm. Yeah, I mean, it's interesting from the research community. We understand that there's costs. We are starting to understand where they are being born, and yet we have to figure out how to communicate this in a way that is motivating and is solutions focused. And I'm curious, Dr. Moore, in your experience, when you were looking at these shifts in the carbon footprint of diets, were you seeing any economic impacts from these shifts as well? I might have missed it.
It's a great question, and it's not one that we directly considered as a part of this work under kind of how the purchases happen in New York City. There are kind of costs that are set, which was not a part of what we looked at in this, but I think it is a huge piece to be a part of the conversation about food and rising cost of food and how much things are costing and the different types of menus and diets and how cost should be a consideration as a part of it. I think the piece, kind of tying into what others have been speaking about too, is just about communication for this work and the opportunities that also exist around food systems and around diets to be kind of a potential lever for climate mitigation as well. But I think
Yeah.
cost is a key piece to include in the conversations in the future around this.
It's definitely something that people think about when they go to the food store, right? And how do we kind of communicate that? It's so important. So this is a question from an anonymous attendee directed towards Dr. Clemens Cope, but apparently anybody can answer it. The question is, or the statement, many outdoor workers are immigrants, sometimes undocumented. Has recent immigration policy had an impact on health effects, both due to being in high-risk employment and less access to medical care due to fear of detainment or deportation?
I'll say that that's a really important and interesting question, and I hope that somebody tackles it in the future. Our data went up to 2023, so I'm not sure that I have intuition to bring from the data, but I think it's a really important question.
Yeah. Anybody else in the panel have anything to comment on this? Okay, maybe the next panel can answer it. Okay, another question here. This is for Dr. Moore. Did you retrieve any data from the city workers on their thoughts on the changes to the meals slash snacks? Were they not as happy, or did they even notice the changes?
Yeah, thank you for that question. Really important piece of it. As a part of this work, we did not directly collect any data from the city workers. However, co-authors on the paper and colleagues in New York City have worked very closely with the New York City agencies and programs on the revisions to the food standards. So it's not a part of this work. However, they work very closely with the people who are implementing the changes to make sure that they are feasible and appropriate.
Yeah, amazing. I think this question could be answered by several people here. And again, from an anonymous attendee, with many state Medicaid programs currently under intense scrutiny and budget cuts with this administration, how do we center climate and health as a priority from a cost savings perspective? And I also note that, some of the existing things we've had like the 1115 waivers are kind of a threat right now. And I know that's been sort of a major lever that states have been using to provide at least some social protections.
Yeah, perhaps I can kick us off. My opinion is that the cost savings are the obvious foothold. I think the circular necessity of needing evidence for them to make a change, but struggling to generate evidence without a change being made in health insurance makes it very difficult to sort of kick things off. I think there are opportunities to run pilots or to borrow evidence from other contexts. To start small, to do all of these, all of these things. The broader threats to budgets is, yeah, that's an existential challenge that I think we'll all have to try to come up with. I'm hoping that there are clever ways to to generate evidence even without sweeping reforms.
Yeah. Anybody else have any thoughts on that one? How can we continue to center climate health equity as Medicaid budgets are getting cut? Okay, next question. This person is interested in thoughts from the panel on growing mental behavioral health impacts and costs, considering that they are not geographically concentrated in the way that many of the other impacts under consideration are. And so curious if anyone here has brought their work into the area of mental behavioral health and thinking about, how do we think about the impacts and how do we think about the costs of this?
I can attempt to answer it. So I think that the crucial thing about mental health impacts is that they are much more diffused and much more and through chronic stress, sleep disruption, anxiety, displacement, and this diffuseness makes costs even harder to ascertain and trace, which is exactly the attribution problem that we have been highlighting. Nearly all panelists have been highlighting. But these costs of mental impacts show up in lost productivity and healthcare utilization and household financial strain as well. But they're rarely ever linked back to climate change. And I think that a lot of work that we've all talked about in this panel needs to go to that ascertainment.
Yeah, absolutely, absolutely. And it's tough. And I think we're seeing this a lot too, World Health Organization coming out and saying, thinking there's something around 250,000 deaths a year attributable to climate change and health. I think as researchers and practitioners, we know that's a gross underestimate, but yet our research methodology needs to evolve so we're able to account for these way more diffuse impacts that are just so hard to capture. And so I think there's just so much more that needs to come on this to evolve in terms of our methods, but also in terms of how we communicate them. We have about 2 minutes left for this panel, so just maybe some closing thoughts. I'd like to sort of prompt this panel by thinking, the theme of this issue is around health equity and climate change. And it's this recurrent theme that the communities who are generally contribute least to the climate crisis often face the greatest burdens. And the question I have for you is, have you seen interventions or policies that are really successfully centering equity, not just as an outcome, but also as a design principle from the beginning in any of the work that you're doing? And if not, how can we continue to sort of focus on equity as an issue central to climate and health research and climate and health interventions?
Well, I'll just say that even though I agree about and the previous point about the effects being diffuse, I do think that starting with the populations, in my case, the workers that are most at risk, really makes sense. And there are three states, Oregon, California, and Washington, that ha really focused on wildfire fighters and protecting them. And that is, in my mind, an equity principle because you're protecting the frontline workers who are really being most exposed. So I think that like focusing on the people who are most impacted seems like an equity move that could be applied across the board.
Yeah, absolutely. And I'm sure, Dr. Boyer, in your work, you involve communities in a lot of the adaptation focused solutions.
Yeah, absolutely. I think I mean it's an interesting question from the Pacific Island jurisdiction point of view because the as mentioned, the contribution to climate emissions is so significantly low. And the vulnerability or the exposure of the populations is so high across the board, but even within these smaller subpopulations. So I think any kind of adaptation plan or climate and health adaptation plan that I've seen or interventions focused have really targeted trying to reach these populations, these high risk populations. But when you have a whole of the population is at risk, most of the populations live very close to the coast, they're highly exposed to storm surge, things like that. So it's kind of embedded into a lot of the work that is already happening. So it's maybe less called out, but I think that's maybe it gets back to the communication point that highlighting that this is more of an equity issue across the board, even if there's a kind of a blanket kind of high risk area. So.
Absolutely. Well, we're out of time. I want to thank you all so much for being part of this panel. Encourage everyone listening to do a deeper dive into the incredible articles and contributions you've made to the special issue. And I will turn it over now to Sakobi Wilson, who is professor with the Department of Global Environmental and Occupational Health and the Department of Epidemiology and Biostatistics at the University of Maryland, College Park School of Public Health, where he directs the Health, Environment, and Economic Justice Lab. Over to you, Sakobi.
Thank you. Happy to be here today. Great panel. I'll be moderating the panel on community-based solutions to the climate crisis. We have 5 panels. Each panel will have 5 minutes, and then we'll go into Q&A as we did with the first panel. So we have Dr. Corey Grant, clinical assistant professor at the University of Houston. We also have Dr. Bradley Kramer, program manager for the Climate and Health Equity Initiative at Public Health, Seattle and King County. Dr. Arturo Bustamante, professor at the UCLA Fielding School of Public Health, and faculty research director at the UCLA Latino Policy and Politics Institute. We also have Dr. Cynthia Strathman, executive director of Strategic Actions for a Just Economy. And our final panelist is Dr. Maud Powell, associate professor of practice in the Small Farms Extension Program at Oregon State University. Dr. Grant, you're up.
Thank you, Dr. Wilson and Health Affairs, for the opportunity to share our work today. As we know, the impacts of climate-related disasters are disproportionately experienced by communities facing systemic inequities. Despite federal reforms, disaster response across the Gulf Coast often remains insufficient and poorly aligned with local conditions. Standardized approaches don't account for barriers related to these inequities, which are realities that shape response and recovery. The result is growing gap between formal response systems and the needs of the communities they serve. This raises an important question. How can we design disaster policies that actively plan for and support the needs of the community? In response, we describe 4 types of community-based resilience hubs, and you can stay on the slide where you are. This is Crescent Care, a community health organization in New Orleans that is a resilience hub powered by solar energy. During disasters, the first floor covered parking area serves as a staging and sheltering space. It has cooling and charging stations for those without power and is a distribution site for food, water, and medical supplies. When Hurricane Ida hit New Orleans in 2021, the electrical grid failed, and Crescent Care was left without electricity for weeks. They had a generator, but it wasn't refueled because the fuel contractors left the city. As a result, they lost the temperature-sensitive vaccines and medications and experienced disruptions to care that had real health consequences for the community. This experience is what led Crescent Care to rethink their role as an integral part of the disaster response system and become the resilience hub that they are today. Next slide. In contrast to the current systems, which can be reactive and centralized, resilient systems withstand, adapt, recover, and transform. They are developed through an ongoing process that is shaped by strong relationships within the community, local knowledge, and adaptive practices. Next slide. The communities in our paper, including Northside Houston, represent the most climate vulnerable in the US when you consider risks like pollution, poverty, housing, and infrastructure. And when these communities have a desperate need for improved infrastructure, we found that vulnerability is not a reflection of the strength of the community or how they function. That even in the most vulnerable, resource-limited settings, communities have built resilience from the ground up. And this shift in perspective should change the way that we think about long-term solutions. We propose 4 models of community-based resilience hubs in the next slide. First is a residential hub created by West Street Recovery in Houston. These are individual homes designed for rapid response during short-term power outages and extreme weather. They are solar powered and contain emergency supplies. The residents in the home are trained in emergency response and function as a network that can quickly reach individuals with medical and mobility needs. The second is a community-owned hub created by Northeast Houston Redevelopment Council. These are physical spaces controlled by community-based organizations that address longer-term resilience gaps. Beyond response, they facilitate planning, resource coordination, and recovery, positioning community members not just as recipients of aid, but as decision-making and makers and first responders within their own neighborhoods. Third is the healthcare anchored hub, like Crescent Care in New Orleans. Many FQHCs are already embedded within underserved communities and trusted by local residents. They are uniquely positioned to serve as anchors within the broader resilience networks. They help maintain continuity of care during disruptions while also expanding to meet broader needs during prolonged outages. And then the last is a local government and community hub, which is led by Precinct 2 in Houston. This model brings together public agencies such as Red Cross and Office of Emergency Management and trusted community organizations such as civic and religious organizations to align communication, resources, and emergency management response and enable multi-site activation. Next slide. Together, these 4 models point to a policy agenda that treats resilience hubs as public health infrastructure rather than supplemental services. We've identified several policy implications during our research. The first is that grassroots organizations should be recognized and resourced as essential responders, particularly in communities where trust and local governance are central to effective response. Second, resilient strategies need mechanisms that support small-scale energy resilience, local supply networks, and community preparedness training. Third, current reimbursement structures can unintentionally reinforce inequities. Funding formulas tied to property values direct fewer resources to lower income communities and provide limited support for prevention or infrastructure adaptation. Fourth, sustainable resilience requires empowering communities to design and maintain preparedness systems. Investment should extend beyond temporary relief to supporting long-term community capacity, including renewable microgrids and community-owned facilities that function as resilience assets. And finally, these models don't require large-scale infrastructure to get started. They build on existing assets, long-term community relationships, and community capacity. And with that, I'll turn it over to Bradley Kramer.
Thank you for having me here today. I'm excited to present on behalf of our co-author team and a broader team that you'll be introduced to along the way. I'm Brad Kramer. I work at the Public Health Department at Seattle and King County that hosted this project. The 2021 heat dome brought about a week of record high temperatures to the region in the Pacific Northwest, and 850 people died across Washington, Oregon, and British Columbia, which really motivated a lot of our heat work. Heat kills even in our cooler temperate climate, and we were surprisingly unprepared. And so the event spurred a lot of immediate attention and from decision makers and to plan for heat. And then I hope you'll agree that the products of our study can help sustain that motivation and action as we approach this 5-year anniversary. So to locate our project, we went to the data, and this is some of the sources that we have a map of that have red hotspots, which are urban heat islands, and these can have evening temperatures that are 20 degrees hotter than the blue spots because of more pavement, fewer trees, and then we also looked at our health disparities map from the state, and this has the red spots are the higher deciles. And you can see our location with the stars co-located in the red areas. And these are cited in our paper. Next slide. So we also found that Auburn, the city that we focused on, was at a different level of readiness. Having the ability to work with the mayor's office, that already hosted a Healthy Auburn for Life community group. And so we were able to go in and work with 15 community members that were identified. These are leaders in the community that have lots of lived and professional experiences across the city of Auburn. And then they signed up to join 6 half-day workshops over about a 9-month period to do our co-design work. We also worked with the University of Washington, and then next slide, and then Sriya Hassan, primary care doc at Emory, who has practiced these co-design methods. We use a method called group model building in our co-design effort, and so this is a series of facilitated and scripted exercises, and has been practiced for a long history across many disciplines and can be very useful to health and climate. And what makes this co-design facilitation and outcome distinct is its use of causal loop diagrams and its close connection to system science, particularly systems dynamics. And so the result is a systems model, a large-scale qualitative model. Next slide. And centered at this model is heat-related illness. And then from there, all the harms that can increase and reinforce this health impact are spiraling out with interconnections. And then the participants sit with this and they puzzle through where leverage points can be put to balance out these harms with solutions, interventions, and policies. When we provide these diagrams in our results, and you should explore the appendix, and then also there's an interactive systems map in the online version. Next slide. And so the team came up with solutions. There's 32 solutions presented in the paper. Here's a few: cool kits for the unhoused, energy assistance for home cooling, education for outdoor workers. And now we have a rich set of place-based specific details of these interventions for Auburn and our suburban heat islands. And several of these took the systems thinking approach and really pushed upstream, more distal from the heat-related illness, such as free medical school to encourage increased community representation and primary care docs. So please check out our tables in the appendix and in the paper. We map these to our sort of local mandates, different city and community-based plans that can elevate this work, and then also we map it to policy action and evidence base. So next slide. This is a community-based participatory process. We tried to we share ownership and knowledge and ownership of knowledge and resources. We tried to shift power. The next step is to bring community voice and wisdom closer to decision making, which we hope can accelerate implementation. We've been invited by the Auburn City Council and the County Board of Health, and here's an example of one of our participants speaking to the Board of Health. This is Saja Ahmed. If you could press play underneath the picture.
And also now, all of us who participate of this project, we have stayed connected, sharing all the resources, not only about heat, but about other essentials in our community. And finally, I want to say that when the government takes the time to really engage deeply with the community, it builds a better capacity and professional development and makes the whole community more resilient. And these voices helps highlight the real needs and challenges, and that makes the solutions stronger and longer lasting. Thank you, everyone.
All right, next slide. We hope that we hope that you find these methods practical and useful in your work, with lots of opportunity to expand this practice across health topics or different climate hazards as well. Thanks again. I'll pass it over to the next speaker.
Hi, good afternoon, and thank you to Health Affairs for the invitation to this briefing. The paper I'm presenting today asks a very practical question. How can public data help policymakers identify climate-related health risks more clearly, target resources more effectively, and strengthen accountability for results? That question guided our work on the Latino Climate and Health Dashboard, a neighborhood-level data tool developed by the UCLA Latino Policy and Politics Institute. The dashboard brings together climate exposure, health outcomes, and neighborhood vulnerability measures that are often housed in separate systems. Our goal was to create a policy tool that helps decision makers see where climate risk and health burdens overlap and where public investments may have the greatest effect. We know that climate change is increasing health risks across California. Extreme heat, poor air quality, and related environmental exposures are contributing to higher risks of asthma, cardiovascular disease, heat illness, and emergency department use. But these risks are not evenly distributed. In California, Latino neighborhoods experience more extreme heat days, higher exposure to fine particulate matter and diesel emissions, and higher rates of emergency department visits for asthma and heart attacks than non-Latino white neighborhoods. The dashboard documents these differences at the neighborhood level. For example, Latino neighborhoods in the dashboard experience about 60 extreme heat days annually, compared with 37 in non-Latino white neighborhoods. They also reported nearly twice the emergency department visit rate for asthma and about 1.6 times the rate for heart attacks. The dashboard also shows built environments conditions that increase risk. Latino neighborhoods had substantially lower tree canopy coverage, more impervious surfaces, and a larger share of workers employed in heat-exposed industries. A key feature of this project was that the dashboard was developed with guidance from an advisory board of community leaders, practitioners, advocates, and policy experts. That process helped shape the indicators, county-level fact sheets, and dissemination strategy. After the dashboard was released, we convened what we called policy platicas, or policy dialogues, with community organizations, public health practitioners, environmental advocates, labor representatives, and legislative staff. These conversations were designed to move from data to policy. Participants were able to review the dashboard findings and helped identify the most urgent issues, visible interventions, and potential implementation barriers. 5 policy priorities emerged from these components. First, stronger coordination across climate, air quality, public health, labor, housing, and emergency management services. Second, sustained community monitoring and early warning systems. Third, targeted cooling and infrastructure improvements in shade, urban greening, cooling centers, housing upgrades, and energy efficiency, particularly in places with the highest combined heat, pollution, and health burdens. Fourth, stronger links between climate policy and health outcomes, including asthma, cardiovascular events, heat-related illness, emergency department use, and preventable hospital utilization. And lastly, climate resilience access to care and worker protections. Policy responses should include preventive care, continuity of care during climate emergencies, enforcement of heat safety standards, and workplace protections. Together, these priorities show why data tools should be designed for policy use from the beginning. A dashboard can help identify the problem, but community-informed interpretation helps clarify what to do next. For policymakers, there are 3 main takeaways. First, climate and health policy should be place-based. Statewide averages can hide important local variation, so neighborhood-level data makes it easier to target interventions where exposure, heat burden, and infrastructure gaps overlap. Second, health metrics should be built into climate policy. If climate programs are intended to protect health, then health outcomes should be part of planning, evaluation, and accountability. And third, data systems need sustained support. Public data tools, monitoring systems, and community partnerships require stable funding and regular updates. Before closing, I should acknowledge that the Latino Climate and Health Dashboard does not estimate causal effects or evaluate the effectiveness of specific interventions, but it offers a replicable model. It shows how public data, structured community input, and policy translation can work together to support more targeted and accountable climate health policy. As climate pressure grows, health policy will need better tools to identify risk, allocate resources, and measure progress. Our work suggests that neighborhood-level data, when paired with practical policy dialogue, can help move from documenting disparities to designing solutions. Thank you. And I'll turn it now to Cynthia.
Hello, everybody. I'll be talking today about empowering South Los Angeles tenants to advance climate policies that protect their rights. I work at SAGE, which is an economic justice nonprofit in South Central Los Angeles. We work with a majority Latino population, which Dr. Bustamante has just framed for us as being at very high risk of extreme heat. Another important part of the context is that over 60% of the renters in the residents of Los Angeles are tenants, and an even higher proportion of folks in South Los Angeles are tenants. California has a lot of policies in place to help reduce the use of fossil fuels and increase resiliency through building modification, policies like decarbonization, replacing gas appliances with electric ones. But in areas of cities where a lot of the people are tenants, enacting those kinds of building-based modifications can be very difficult. So maybe we can move to the next slide. The tenants that we work with are reporting a lot of very dire impacts from extreme heat. A lot of rental units in South Los Angeles do not have indoor cooling. There's very little green space, and community members will try to beat heat with homemade methods like sleeping with ice packs or just using fans all the time, but still the impacts are really hard on them. One tenant described being passing out in her apartment from the heat and then being taken to the ER because she just wasn't coping with it. And amenities like theaters or malls are not as common in low-income areas, so they have many fewer options for just trying to get out of the heat. Next slide. One problem that tenants face is that unmotivated or unscrupulous landlords are not really willing to spend the money to even maintain the buildings, let alone put in cooling systems. So not all landlords are bad. I don't want to paint everybody with the same brush, but many are trying to just maximize their profits. They don't want to install cooling systems because they're expensive. Sometimes they don't want tenants to do it even at their own expense because they don't like the aesthetics of it, the way it looks on the building. And some buildings may need remediation before you could even install cooling equipment. And I want to highlight here that there's a really unusual arrangement in the United States between landlords and tenants. Usually, we wouldn't really tolerate the widespread abuse of customers or clients who were spending thousands of dollars on something. But for some reason, I think landlords are often offered a lot more social and cultural leeway that way. So if we can move to the next slide. An additional issue that tenants face, besides having landlords who just don't want to do the work of improving the building, is that landlords can use building improvements, especially mandated building improvements, as an excuse to harass or evict tenants. And even without mandated, heat related improvements, tenants are reporting that landlords will use renovations as a way to try to get rid of them. We had one landlord who just completely removed the kitchens in all of his units as a way to try to get the tenants out and hasn't replaced them for months. And low-income tenants in rent-stabilized buildings are especially at risk because landlords stand to gain so much if they can get those tenants out and raise the rents. So anytime we're doing a building-based climate adaptation that's going to be mandated, we really need to, I think, tread carefully to make sure there aren't some unanticipated harms. So if we could move to the next slide. So to make change, we're really focusing on how we can empower and educate the tenants that we work with to be able to make the change that they need. This is not always easy. Tenants in South Los Angeles can be preoccupied with many immediate concerns, finding and keeping jobs, finding and keeping housing, dealing with immigration enforcement. Like people really have a lot of on their plates already. And a lot of the changes that need to be made really need to be made by landlords, which is going to require policy changes and also a real shift in frame, I think, in policy making from an emphasis on property rights to an emphasis on housing as a human right that the people who own it have an obligation to respect. And in addition, tenants are afraid that changes will be expensive, that those expenses will be passed on to them, or that they will lead to their eviction. However, tenants, I think, are also really primed to understand the importance here of building-based changes because they already deal with so many heat-related building or building-related health problems. So for one example, we're working with the Los Angeles Climate Emergency Mobilization Office to solicit community feedback on something on decarbonization policies. And tenants were very apprehensive about it to start with, but they very also quickly reached the conclusion that this has to happen, but they just want to be included in a lot of those discussions. So for the last slide, which is the next slide, what we found is that with education, tenants really can successfully advocate for climate change solutions. We've had tenants attend meetings with LA City and county officials. They've testified at public hearings. They've attended press conferences, and they've worked with us to develop policy elements that they wanted to see passed. And we've supported tenants working with municipalities to pass legislation forbidding the use of remodeling as a pretext for eviction, which passed in LA City in the August of 2025, and are also working on cooling mandates for buildings at both the county and the city level. So our real goal here is to keep tenants engaged in these civic processes so that when policies are passed, they include their input and are also a way for them to become more actively involved in civic affairs and local democracy. So thank you very much for an opportunity to talk about our work in South Los Angeles. And I will, with that, pass it on to Maud Powell from Oregon State University.
Sorry about that. Thank you so much for the opportunity to speak today. My name is Maud Powell, and I am speaking on behalf of my co-authors on our commentary, How Climate Change is Affecting Farmers and Ranchers' Mental Health. I'm both a professor of practice with Oregon State University Extension, and I'm also a farmer. So the research and intervention described in our piece are grounded in lived experience. They emerged from my own difficult decision to leave our farm of 23 years following the unprecedented heat dome of June and July 2021, already mentioned in this panel, which forced my family and I to realize that due to the intensifying drought conditions on our property, we could no longer farm there. So farmers and ranchers, like my family, are on the front lines of climate change, experiencing drought, extreme heat, weather, wildfire, and increasing production volatility. So our commentary really underscores the fact that these impacts are not just economic or environmental, they are also deeply psychological. We argue that climate-related emotional distress, especially climate grief, directly affect farmers' capacity to adapt, to plan, and to remain in agriculture. And yet, mental health is largely absent from climate adaptation policy and agricultural resilience frameworks. So the core policy problem that we outline is that there's a mismatch. We ask farmers to carry the burden of adaptation without adequately supporting their emotional and psychological resilience. And if you could switch to the next slide, please. Thank you. So a central finding of our work is that climate grief, which is grief related to actual or anticipated climate losses, is widespread among farmers and ranchers and should be understood as a legitimate and predictable response and not an individual pathology. So these losses include diminishing irrigation supplies, changing ecosystems, declining crop viability, and the erosion of intergenerational farming futures. We document that these emotional impacts accumulate over time and remain unresolved. In a 2024 survey of Oregon farmers that some of the authors on our commentary conducted, we found that 88% said addressing climate-related stress and grief is important, yet this need remains largely invisible in agricultural and health policy. So the implication is clear. Ignoring climate grief and climate distress means underestimating both human need and the systemic risk in our food systems. Next slide, please. So the commentary makes this connection between mental health and climate adaptation capacity. So what we know from research is that chronic stress, anxiety, and despair actually impair our ability to plan, to problem solve, and to engage in long-term decision making, all of which are essential for farmers and ranchers to adapt to climate change. So these climate-related stressors do not occur in isolation. They compound existing pressures from trade instability, shifting farm policy, labor constraints, and insurance uncertainty. We also situate these findings within broader evidence that farmers already experience elevated suicide risk and substance use compared to the general population. So from a policy perspective, this is not simply a health issue. It's actually a workforce sustainability and food system resilience issue. Next slide, please. So we also describe in our commentary a USDA-funded pilot intervention that some of our team developed through the Farm and Ranch Stress Assistance Network. And in our model of intervention, we use brief group-based psychoeducation to help farmers to name their climate losses, to normalize emotional responses, and to share resilience strategies with peers. Importantly, it avoids politicized language and centers lived experience. So far from these interventions, the outcomes are notable. 91% of participants said identifying climate losses would help them manage their stress. 87% intended to adopt new coping strategies. So this, for policymakers, this can demonstrate that effective interventions can be low cost, scalable, culturally responsive, and delivered through trusted agricultural institutions, including extension and community providers. And then the final slide is we want to conclude with our clear policy message that climate adaptation policy should also address the full spectrum of challenges that farmers face. Again, both physical, economic, and also psychological. So currently programs like the Farm and Ranch Stress Assistant Network, they do represent progress, but they remain relatively fragmented and under-resourced. Ultimately, we reframe farmer mental health as a form of resilience infrastructure. If policymakers expect farmers and ranchers to continue producing food under increasingly volatile conditions, we need to invest in emotional well-being. The closing line of the article says it simply, climate grief is real and it's time to treat it as such. Thank you so much. And I think we'll go back to the moderator.
Thank you, Maud. Thanks for that great presentation. Thanks to the panelists. Now we're going to go to Q&A. If you have, for the attendees, if you have questions, please put them in the Q&A box. I'll get it started though. Like I said, great presentations. It was interesting to hear the themes of Dr. Bustamante, maybe Dr. Strathman, some others. How have you talked about heat and also community-based solutions to other, types of extreme temperatures? So are you looking at just heat, or are you also looking at extreme cold as well? And how has your community work been responsive to both, and how those solutions could be applied to both extreme heat and also extreme cold? Dr. Grant?
Sure. I think I have examples from all of our different models for responding to cold. For example, the neighborhood, the residential hub that's a home, the leader of that actually started the community-based organization after experiencing an episode of extreme cold that nearly took her life. So that sort of spurred the work that came out of that.
Thank you. And go ahead, Dr. Kramer.
So I would just add that, in this temperate climate that we're in, extreme cold events and extreme heat events can really stress our preparedness system and show us where we might be unprepared, especially if these events are increasing in intensity and frequency. And so we are doing a similar process with extreme cold. We haven't started the group model building process yet. We'd love to do that if we could get funding, but we have followed a similar process working with partners like the University of Washington and the National Weather Service. We did this previously, which built that heat risk tool that has gone national, where it's able to set thresholds to activate under extreme heat. And then we're also looking at different products that we can develop for extreme cold. But part of that process is similarly getting people in the room together around round tables and doing different types of sort of community input to develop out those solutions and see where we need to put efforts for future work.
Thank you for that. I want to go back to Dr. Strathman real quick. So this question about extreme temperatures, would be heat and cold, and I mean, I was really intrigued by your presentation about tenants. How integrated has like the healthy housing framework been part of your work, looking at tenants and housing and climate resilience? Has that, and how have you engaged with city leadership, agency leadership, in integrating that framework and to really bring health, that framework into the work as you're doing the empowerment work with tenants?
I think we are going to start doing it more. We used to actually do more healthy housing work probably 10 years ago, but what happened is that the affordability crisis really caught up and sort of superseded that in terms of stressors for the community members. So where we used to have we still have a lot of problems with mold, vermin infestations, things that cause really dire health outcomes. A lot of times now, tenants' primary concern is, how do I manage to not get evicted, and how do I manage to not have insane rent increases. And those, of course, are linked, right? I mean, as we saw, we can't do some of this housing mitigation where we're mandating that landlords fix things unless we also have a program to make sure that they can't use those as an excuse to evict the tenants. So it's all kind of it should all be integrated. And I think that we're going to have to return now back to more of a healthy housing frame as we address some of these climate related issues in a way that's improving the building's health while also ensuring that the tenant doesn't end up on the street.
So, no, thank you for that. Great response there. So I want to go to Dr. Bustamante a little bit, and just kind of dig back in to your tool. So I was definitely excited to see the dashboard and how those types of tools can be useful in the process of engaging the folks who are most impacted to help inform it. And you made some comments about it's just not about data, and it's not you can't show causality. But can you speak to sort of the innovation and the impacts of that tool? Where is the tool going, right? Can you do tracking with the tool? Can you get more hyper localized data with the tool? Can you kind of speak more to those points?
Yes, of course. Yeah, we were very excited first when we started this project to engage with different community members who could potentially use our product on what could be the most effective way of communicating their main situation, ideas, and policy proposals to policymakers. And many of them share with us this situation where they say, we work in NGOs, we don't really have technical capacity to do all these data analysis. So trying to assemble a proposal from us to policymakers is quite difficult in terms of technical capacity, and also the cost of having someone doing that type of analysis. So that was one of the main motivations for us to actually do something that could potentially be useful to community organizations. So that's why this tool puts together measures from different databases that are spread out together. It would be complex to put this information together at the neighborhood level, so that we could provide these measures at the county level and at the state level for advocates, community organizations, to show what are the problems that they face based on climate change and health outcomes. So I think from the beginning, from the design to that, what type of measures to prioritize, and to the implementation and dissemination of this information, we were always engaged with this community spirit of trying to make something that is useful and applicable. And then the second part of this dashboard project was precisely the convenings, where it's always important to hear from people who are in the field, not only from policymakers or from academics who many times we think that some policy solutions are more important than others. When we actually shared those ideas with the community, with policymakers, with union representatives, with government officials, there's different perspectives, and putting that in the same roundup table and trying to prioritize those based on what is feasible and what is not is always a very useful exercise. So honestly, I learned a lot from this exercise. I really liked it. And I think it's a model that could be replicated to other communities, other states, other types of measures in terms of climate change and health outcomes.
Thank you. I'll make a real quick comment and go to the next question from the audience, from the attendees. Yeah, I do a lot of work in building environmental justice screening and mapping tools. And it was very much community engaged. Our unit of analysis is track level. We're trying to get down to the block group level. We have environmental justice scores for census tracts, for school districts, for legislative districts, and really to make it more useful. To your point, it's getting down to the neighborhood level. And I know Grace from Houston is on, working with the colleagues in Houston. They have a climate vulnerability index. So these mapping tools, these dashboards, that I think are just in general very useful to visualize the concerns, visualize the communities, and they help you identify, prioritize, and micro-target the intervention. So I just want to advocate and support your dashboard and other types of tools that we can get to the hands of folks at the local level. Just wanted to make that quick comment. Real interesting question from Susan, one of the attendees, about Senator Maud. She makes asks a question really around the One Health model. We're talking a lot about human health impacts of climate change, but what about impacts on animals? So can you speak to, you talked about climate grief and climate stress for ranchers. What are they seeing as it relates to the impacts of climate on in animal husbandry on the ranch, at the farms? And what did you what have you seen in your own experiences as a farmer?
Yeah, well, I've been in crops personally as a farmer, but certainly we work with a lot of ranchers who report death amongst livestock, increased disease pressure, and just watching livestock suffering. And it's certainly creating a need for more infrastructure, for more shelter, an increase in the need for water, so animals have access to clean water as the evapotranspiration rates are higher, and it's harder to have water available to livestock. So certainly that's coming up a lot in our work for sure. Absolutely. We're also seeing a decline in insect population, beneficial insect population. That comes up a lot that farmers are reporting as well. And I did want to mention the last question that you had, Dr. Wilson, around cold weather as well. I just did want to mention that in my experience, drought and heat and wildfire have been the greatest concerns for farmers and ranchers, but certainly in other parts of the state and the country, we're seeing, these increase in Arctic blasts and polar vortex disruption, as well as atmospheric rivers up in the Skagit Valley in Washington, ice storms as well that have been really destructive. So again, I'm looking at mental health impacts, but really it's around climate instability, and in some cases that is really cold or very wet events as well.
Thank you. I'm gonna modify the question from, again, my colleague, Dr. Grace T. Lewis. Question about federal funding. She asked about, can you speak about the barrier to federal funding for housing that's climate vulnerable? For example, limitations on HUD funding if a household is in a flood zone. But for any of the panelists, I know maybe to Bradley or to Corey, if you want to chime back in, or even to Cynthia, what's been the impact on your work as it relates to federal funding to be able to work with the population you're working with the parties you're working with, to make sure you can make that infrastructure, those communities, more climate resilient? So I'll go to Corey first.
I am not sure I can answer that question. Sorry.
Okay, you're fine. I'll let Bradley take a shot at it. Go ahead, Bradley. Thank you for that, Corey.
Well, I do think that there are solutions that have been historically housed at the federal level or initiated there with weatherization programming and with low income. I'm gonna get the acronym wrong, but low income
LIHEAP. Yeah, the
LIHEAP for
Yeah.
energy assistance programming. And so these are essential policies that definitely came up in our process and are mentioned in our work, and there are state equivalents as well that can supplement and bolster those, and those are essential resources that are working and can continue to work. And in particular, we've done work on weatherization plus health, where we go in and combine asthma programming with these solutions that, when you seal up the home to make it more energy efficient, you're actually reducing the influx of all of the allergic triggers to asthma and improving health. So as you begin to add health programming onto it, this is behavior change, and folks are motivated to upkeep their new major home renovations to protect the health of their family. But then also these are major climate solutions too. These are energy efficient programs that are reducing our carbon footprint. So it's really a win-win-win. And so those are a couple examples.
Thank you for that. Corey, I'm gonna come back to your question that hopefully you will be able to answer for us. I really do appreciate the hub model. We have something called the Mid-Atlantic Climate Action Hub. And so we're working with communities, frontline frontline communities that are experiencing environmental climate issues, help build their capacity, give them technical assistance to address their, the climate hazards that they're experiencing, the communities they serve are experiencing. So Do you think your four models that you presented, are those things scalable? Can we replicate it? Are you already doing that in other parts of Louisiana, other parts of the Gulf Coast? Yeah, can you speak to that?
Sure. A couple of them are the model that is within the FQHC is absolutely scalable, especially to rural areas where where they already exist. And then the residential homes are currently located across different areas of the city of Houston, but they've been contacted by several organizations to share their model in other areas. So I believe that will soon be spread across outside of the state of Texas if it's not already.
Yeah, thank you for that. So we are at time. I just want to thank the panelists for the great presentations. I think for me, this is really important work that you're all doing and showing it from different parts of the country. I think we have to have community communities are most impacted. The folks are most impacted have to be driving the solutions. And I think your presentations really talk to that with the system science, what I thought was very innovative. I love dashboards and tools. The focus on tenants and housing, making sure that folks speak with their own voice culturally, and some of the work that Arturo talked about. And then this hub model, I think is very powerful. So I just want to thank Maud for the focus on farmers. We don't speak enough about that. And that was very interesting, Maud. Climate grief, I think, is that same as climate anxiety. So thanks for defining of what climate grief was. So we appreciate y'all, appreciate your time, appreciate the great work you're doing, and really want y'all to be able to share this with other folks across the country so we can make sure other communities are experiencing the same issues and populations, stakeholder groups like ranchers, farmers can benefit from it as well. So thank you again. I'm going to pass the mic to Meg, who's going to take us into the next session. And Meg Winchester, who is Health Affairs Senior Editor, going to speak about health systems approaches to climate adaptation. To you, Meg. You have the mic.
All right. Thank you, Sakobi, for the introduction, and thank you all for your continued attention. Welcome to session 3, Health System Approaches to Climate Adaptation. I'll kick us off by introducing our speakers in the order in which they'll be presenting today. First, we'll have Jeff Romine, a research scientist at Carillon Research. He's an environmental economist with his PhD from UC Santa Barbara. Next, Genevieve Silva is a medical resident at Penn Medicine Doylestown Hospital and lead for health systems decarbonization research at Green Health Lab at Dartmouth. Dara Patel is a primary care physician and research fellow at Cambridge Health Alliance and Harvard Medical School. Sebastian Bauhoff is principal health economist at the Inter-American Development Bank. And last but not least, Aaron Marcus is professor of clinical medicine at the University of Miami. A quick reminder that you can put your questions in the Q&A box as we go along. You don't have to wait till the end. And with that, I will hand things over to Dr. Romine.
Hi, all. Thanks for having me. I'm very honored to be on this panel with all these great panelists and excited to hear their great work. But we're trying to understand the association between high heat exposure and healthcare utilizations and costs across different age groups and different types of insurance. So the quick takeaway from our research is that, unsurprisingly to anyone in attendance here, is that when we associate heat exposure to utilization costs, we find increases across the board. But what we find in this paper is we're looking at extreme heat and utilization and cost across Medicare, Medicaid, and Medicare Advantage individuals. We see, unsurprisingly, that ED utilization increases when it's hot. We also find that costs increase, and for some individuals, we see that inpatient utilization increases. So what we find is that when an individual is exposed to a temperature over 100 degrees, instead of being between 60 to 70 degrees, that their average weekly utilization and cost, so we're doing it at the tract level, so tract level average weekly utilization and cost increases by 1% for every day that a tract is exposed to heat over 100 degrees compared to if it had between 60 to 70 degrees. So if we had a heat wave where we had 7 days over 100 degrees, we would actually see about a 7 to 10% increase in cost and utilization. And hopefully what you guys heard earlier is I said that for some populations, such as children with commercial insurance, those individuals with Medicare Advantage and people who have Medicaid coverage who are working age see an increase in inpatient utilization. So this inpatient utilization is about a 0.5% increase in weekly utilization for 1 day over 100. So if we had 7 days over 100 degrees, it'd be about a 3.5 to 5% increase in inpatient utilization for Medicare Advantage individuals. So what is unique about our paper is really the scope and the scale of this study. So we are able to have 40 million individuals in our study across all 50 states and across 8 years. So what we're doing is we're able to take their contemporaneous heat exposure and correlate that to their different, how their utilization and costs are associated with this heat. So we look across the different places of service, and it was been pretty well shown that ED utilization and cost increase in the literature. Our inpatient findings are also semi-established. What's completely new is our cost measures and our outpatient utilization and cost. So we actually find that outpatient utilization is not correlated or not associated with an increase in heat. So when it's hotter, we don't really see an increase in outpatient utilization or costs. But as I said, our cost data is very unique that we're able to actually see that utilization and cost trends similarly. So it's kind of an open question whether severity may change and it may change costs when it's hot, but we don't see that show up in our data. So we see that if there's about a 1% increase in utilization associated with extreme temperatures, we see about a 1% increase in cost. So since I had those technical difficulties, I'll try and wrap up a little bit, but really just the main takeaways that I want everyone to have from this is that extreme heat can be predicted. It is something that can be expected. And there's things that, and our papers show that there should and can be things to try and mitigate these damages. So across the board, whether it's someone who is a child or someone who is on Medicare Advantage, we see that heat is exacerbating illness. It's making people go to the emergency department, and it's even putting people into hospital beds. So apologies for the Zoom difficulties, but I'm going to now pass it on to Dr. Silva for the next presentation.
All right, hi. I'll be presenting on behalf of my co-authors listed here on our paper entitled U.S. Hospital Community Needs Assessments, Climate-Related Health Risks. Next slide, please. U.S. nonprofit hospitals, which comprise roughly 50% of hospitals in the country, must conduct a community health needs assessment, which I'm going to call CHNA moving forward, once every 3 years in order to maintain federal tax-exempt status. These are used to inform hospital action plans, such as community health improvement plans, and also to guide investment decisions. The IRS publishes general guidelines for what must be included in these CHNAs, but federal rules do not require specific consideration of climate-related health risks, despite evidence that climate change is projected to continue impacting health outcomes significantly. Next slide. So in this study, we aim to evaluate the extent to which U.S. hospital CHNAs currently address climate-related health risks and whether or not this relationship was modified at all by geographic region of the hospital, hospital type, or degree of community's climate vulnerability. Next slide. To address this research question, we evaluated a nationally representative random 20% sample of CHNAs from the pool of all available U.S. nonprofit hospital CHNAs that were published between 2021 and 2024. We then generated a list of climate and health-related keywords, which were used to conduct an in-text search for instances of relevant context. Co-authors then manually reviewed and analyzed the context of these climate-related keywords in each CHNA. Using an 18-point scale that we had developed to score the breadth and depth of climate-related content in CHNAs, we analyzed the relationship between each CHNA's climate content score and regional climate, vulnerability, geographic region, and hospital type. With this scale, a higher score, closer to 18, represented more robust climate content. We approximated climate vulnerability using the Climate Vulnerability Index, which is a tool from the Environmental Defense Fund and Texas A&M that considers socioeconomic, health, and extreme event vulnerabilities. We also looked at the FEMA National Risk Index, which estimates expected annualized loss from 18 natural hazards by US region. And we quantified geographic region by census tract. Next slide. So essentially, we found that hospital CHNAs across the board did not include significant climate content. Out of the total possible 18 points that a CHNA could score, remembering that 18 means the most robust climate content, the average score across all CHNAs was 2.51. Plus, nearly 1/3 of hospitals actually scored 0, meaning that they contained none of the climate-related terms. There was a geographic relationship that we found, with CHNAs from hospitals in the northeastern and western US scoring roughly 2 times higher than those in the South and Midwest. And paradoxically, CHNAs from hospitals in more climate vulnerable areas had less detailed climate content, and those in the most socioeconomically vulnerable communities also had some of the lowest climate content scores. Next slide, please. These tables show the data behind some of those key findings. The left-hand table demonstrates the association between hospital type and climate content score. Critical access hospitals had a significantly lower score than short-term acute care hospitals, which were the reference point and comprised the majority of hospitals in our sample. The middle table illustrates the geographic relationship I mentioned in the prior slide, that the Northeast and West had significantly higher climate content scores. And the right-hand table demonstrates that both overall vulnerability and socioeconomic climate vulnerability indices were associated with lower climate content scores. Next slide. This map of the US just further illustrates these key findings. The red dots on the map represent the least amount of climate content in a CHNA, while green dots represent the most. The shading of the map represents climate vulnerability based on the Climate Vulnerability Index, with darker shading representing more vulnerability. So as you can see, kind of zooming out and looking at the map, green dots are rare, and the presence of those green dots is not correlated with areas of darker background or higher vulnerability. Next slide, please. So climate risks are largely absent from CHNAs, and the gaps are largest where risk is highest. A variety of policy recommendations may help to address this moving forward. Firstly, the IRS guidelines for CHNAs could be strengthened to include requirements for specific climate health indicators to be considered, for local hazard mapping to be done, and for climate risks to be prioritized for inclusion based on information around health equity impacts. Incentives could also include incorporation of accreditation body review, such as from the Joint Commission, or at the state level, tax exemptions tied to climate-informed CHNA benchmarks. Finally, just to mention, we encountered a fair amount of missing data during our study, with a fair number of CHNAs not discoverable online. So creating a centralized public database overseen by a governing body such as CMS could help to promote data transparency and to inform future work in this space. Next slide, but thanks so much. Oh, and I'll pass it off to Dara Patel.
Hi, everyone. I'm excited to be a part of this panel and discuss our work in the climate, health, and equity theme issue, which focused on cold-related illness hospitalization trends in the US. Now, when people think about climate change and health, the most common topics that may come to mind are heat, air pollution, wildfires. But our study highlights that hospitalizations for cold-related illnesses, such as for hypothermia or frostbite, are rising rapidly in the United States, even in a warming climate. And in fact, cold-related illness, or CRI, hospitalizations have tripled over 25 years and come with a 4 times higher in-hospital mortality risk compared with all other hospitalizations combined. So you might be wondering, if the climate is warming, why are cold-related illnesses increasing? Next slide, please. One reason is that climate change can disrupt the polar vortex, a band of cold, frigid air that normally stays near the Arctic, as you can see on the left side of this picture. With rapid warming in the Arctic, that vortex can periodically become unstable, releasing frigid air that can plunge far southward, as you see on the right-hand side of this picture. Next slide, please. You can link this to our extreme winter season recently, or some may remember the devastating Texas winter storm in 2021 that caused power outages, water shortages, and an estimated 300 to 800 deaths. Next slide, please. Our study analyzed a national data set of all U.S. hospitalizations from October to April, which are traditionally considered the cold months in studies. And we looked at those months annually between 1998 to 2022. And I'm going to quickly share a few of our findings. The y-axis here shows our CRI hospitalization rate, and the x-axis is year. The scatter plot was our observed rate, and the solid line is our age and sex standardized trend line. During the 25-year study period, the rate tripled, going from 42 in 1998 to 123 in 2022, which equates to an annual rate increase of 3.4 CRI hospitalizations per 100,000 all-cause hospitalizations. And we wanted to make sure that our finding was reflective of the true population at risk, which is everyone living in the United States. Next slide. So we compared our rate of CRI hospitalizations per 100,000 all-cause hospitalizations. We compared our rate of CRI hospitalizations per 100,000 all-cause hospitalizations, as you see on the left-hand side, to CRI hospitalizations per 1 million adults in the US, as you see on the right y-axis and the trend line in orange. It's clear there's a similar temporal pattern between the two measures, which confirmed to us that our finding adequately captured population-level trends. Next slide, please. Not only is the CRI hospitalization rate increasing, but that burden is not evenly distributed. We analyzed key psychosocial vulnerabilities that may cause people difficulty to protect themselves during cold spells, and found that CRI hospitalization rates rose significantly faster for patients with versus without each of these vulnerabilities. The steepest annual rise, which you see here, occurred in CRI patients experiencing housing insecurity, as seen in the blue, compared to CRI patients without housing insecurity, as you see in the orange. Next slide, please. Just to summarize the main findings of our work, we found that the CRI hospitalization rate tripled over 25 years, and the patients most affected were those experiencing housing insecurity, those living in high poverty neighborhoods, and individuals with substance use disorders or mental health conditions. And CRI patients, once hospitalized, faced a 4 times higher in-hospital mortality risk compared to all other inpatients. Next slide, please. The rise in CRIs in the context of climate variability should be a matter of public health concern, especially given the substantially higher mortality risk. And the psychosocial vulnerabilities we examined also have become a greater concern in the United States. Housing insecurity and the US homeless population has been rising since 2017 after a long period of decline, in part as a result of affordable housing shortages and rising rent burdens. And substance use disorder-related morbidity and mortality has been largely driven by the evolving opioid epidemic, with the highest numbers of deaths seen in 2022. As we're all seeing, the One Big Beautiful Bill Act has pushed forward significant Medicaid and funding cuts, which we anticipate will undermine access to treatment of conditions that place individuals at higher risk of CRIs. Next slide, please. With our findings, we foresee a few policy interventions that could alleviate adverse climate-related health outcomes. First and foremost is slowing down climate change. This could be mitigated by several mechanisms, including implementing policies that limit CO2 emissions. Additionally, policy reform should prioritize expanding LIHEAP, or Low-Income Home Energy Assistance Program, and other related utility subsidy programs to keep homes warm. Strengthening behavioral health services access and coverage to reduce the prevalence of vulnerabilities that put people at higher risk, and scaling up housing assistance to reduce housing insecurity. And in the acute response approach, we should expand emergency shelter capacity and enhance cold weather outreach programs. Such measures are necessary both to protect against cold exposure and to moderate widening socioeconomic inequality under climate change. Next slide. Thank you. I will pass it off to my colleague, Dr. Bauhoff.
Thank you so much, Dara. I'm pleased to present this paper on From Crisis to Strategy on behalf of our author team. The starting point for our piece is really that many health systems were designed for stability, like predictable demand, steady supply chains and budgets. They were built around averages that these days no longer exist and won't in the future. And as we heard already in the event and from the previous speakers, the baseline conditions under which health systems operate are changing. Shocks are becoming more frequent, chronic stressors are accumulating, and these two compound each other. So risk and variability is really becoming more important to health systems and increasingly disruptive to core health system functions and health system goals. Costly also in terms of money and in terms of population health. So in our contribution, we ask what would it look like to manage risk systematically rather than just responding to crisis when it comes along. So the core of our argument really is a reframing. Health systems, of course, already manage risk in clinical care and public health and also in emergency preparedness and response. But at the system level, risk is mostly managed after the fact through emergency response and things like contingency funds and recovery. And we basically argue in the paper for moving that logic just upstream to get ahead of the issue and shifting from a reactive crisis management to more of a proactive and strategic adaptation and risk management approach. Now, there's a lot of work on this already done in disaster risk management, and we draw on that work and apply it to health systems. And it really starts by recognizing that this risk to health systems is often originates from an intersectoral operating environment like energy, water, transport, supply chains, and so forth. And a hospital that is losing, for example, power after a storm isn't just because of issues in the health sector or in that particular facility, but it's also an issue with energy and electricity infrastructure. So there's sort of a change in the intersectoral environment in which the health systems and individual health delivery platforms operate. And so that's why we must look beyond the health sector itself and thinking about managing risk. And then within the health system, weather events can really hit both the demand and supply. There can be demand surges, like more heat illness, like Jeff and Dara already said earlier, more respiratory disease, and so forth. And that happens at the same time as supply is disrupted as well. So it's really a double bind that makes these events in many ways different from other shocks and sort of requires more attention to the risk management aspect for the health systems part on these sort of weather-related events. So in the paper, we put this together into what we call a layered framework for managing risk that looks at specific components of risks, like, for example, hazard, exposure, vulnerability, to clarify what the source of the problem is and to make this issue a bit more tractable. Then there's the intervention level, including this intersectoral operating environment that I mentioned, but also looking at within the health system where to intervene, either on the population health or the service delivery side. And then there are different time horizons at which we might implement interventions and hope for benefits from these interventions, of course. And in the paper, we have a couple of examples and policies and interventions that map to these three different layers. So I invite you to take a look at that. Next slide, please. So let me maybe close this with my final slide here with the rationale for acting now to become more proactive about managing these risks. First, it's sort of I think a key item is that routine performance. These investments in the approaches for managing risk and for reducing risk, things what we heard already, but also, let's say, adding flexible workforce, diversified supply chains, redundant infrastructure and service delivery platforms. They also often improve everyday systems performance, whether or not a shock arrives. This is not specific to just dealing with risk, but also generally good for health systems performance, really in many ways sort of no regrets type investments. Then secondly, there's a business case. Risk management is often cost saving, for example, by avoiding costs for rebuilding or reconstruction, but also to avoid operational disruptions and disruptions in care delivery and so forth. And then finally, of course, there's the hope that these interventions can also help mitigate impacts on people and patients. Now, there are tools and sort of policy opportunities already to do this risk management in practice. In our paper, we sort of take a global perspective, but there's a few examples also for the US, of course, and our previous speakers like Jeff and Genevieve already mentioned some specific examples as well. So just to say that there's already a lot of tools and possibility to actually putting this into action with a maybe more strategic approach and sort of a broader approach to put these tools into practice. And so again, the important issue, I think, is to really start managing this risk proactively to get ahead of the issue and in many ways to reduce the need for reactive crisis response. And the bottom line of all of this, and this is the argument I'd leave you with, is that this strategic risk management doesn't really compete with existing health system priorities, and instead is often complementary in that this risk management and sort of investments in resilience can contribute to existing health system goals and improve routine health systems performance. So thanks so much, and I'll pass it on to Dr. Marcus.
Thank you. Let me turn the volume up. Okay, great. Okay, I am an academic internal medicine physician in Miami, where I direct a residency training clinic and serve as associate program director of an internal medicine residency training program at a large county hospital. And in my Narrative Matters piece, I discuss my experiences with Hurricane Irma in 2017. Next slide. The clinic where I work is the primary care continuity site for 48 young internal medicine trainee physicians from around the world. Most aren't from Miami. Most don't have a lot of local family support or experience dealing with hurricanes. We take care of low-income patients from the county, most of whom live in households with incomes that are below or close to poverty level. And as South Floridians, we're well versed in preparing for hurricanes. And at the beginning of the year, our program surveys residents about who would be willing to staff the hospital during a hurricane event and who would prefer to staff it after. Next slide. We're used to the threat of hurricanes in South Florida, but Irma seemed different. It hit the Eastern Caribbean as a Category 5, destroying 9 out of 10 buildings in Barbuda and seemingly barreling right toward us. Next slide. So here you can see some of the headlines that were blasted at us prior to the storm, as well as a map of flood zones, which correspond to evacuation zones in Miami-Dade County. For Irma, people in the red and orange zone were instructed to evacuate, and this comprised a huge portion of the inhabited part of the county. But the problem was where to go. So flights out were booked many days in advance. And for those of us who were obliged to stay in town for work, hotels outside the flood zone were also booked days in advance. And a lot of doctors called the hospital administration at the last minute, hoping that they could camp out at the hospital. And they were told no, there was no room for extra people if they weren't on the during team. And there was a massive traffic jam as more than 1.8 million vehicles hit the road. Now, I was lucky because I had been studying spaghetti models of the storm, and days in advance, I was able to snag a hotel room for my 88-year-old mother, my husband, my 2 kids, and my 2 cats, without whom my mother would not evacuate. And our hotel lost power when a tree fell on the generator, but overall, we were really fortunate. The storm turned south at the last minute. It inundated Cudjoe Key, which is a small island in the middle of the Florida Keys, and then it headed to the southwest Florida coast, where it caused a lot of damage. But even so, in Miami-Dade County, there was still a lot of damage, and most of the county lost power for many days, in some areas, weeks. And there were about 1,000 homes that had significant damage. Next slide. So during the storm, the residency program activated the emergency system, the plan, on Saturday, September 9th. And during the storm, it was relatively quiet because people had to stay off the road and there weren't a lot of patients coming in. But then after the storm, the after team had to come in on Tuesday, September 12th. And in a subsequent survey, the residents who had to come in told us that they were really stressed because they had to figure out on their own where to go, when they had to evacuate. And then when they did come into work, they faced a deluge of patients who were really ill due to postponing medical treatment or running out of meds. And in the clinic, our clinic did open up pretty quickly. Many of our patients were coping with no air conditioning, with damaged roofs, and with a lot of anxiety. And nearly all of them lacked the money to cope with these disruptions. And we saw a lot of flares of asthma, heart failure, and hypertension, and mental health issues. Our resident trainees were also really stressed, both on the job because there weren't a lot of resources such as mental health or financial help to help these patients, and also at home because many of our trainees had to contend themselves with damaged apartments and no air conditioning. And one of my residents who lived in an area called Edgewater had a flooded apartment. And these are some of the responses from open-ended questions on a survey of residents after the storm. And most respondents said they felt more anxious or stressed after the storm. Next slide. So post-Irma, there was increased mortality among nursing home residents and among people with chronic illnesses in the 2 months after the storm compared with the previous year. And this mirrors findings from other storms, such as Hurricane Maria in Puerto Rico and other storms too. And as people are stressed and their lives are disrupted, you see an increase in mortality in the months after these storms, particularly among frail people and people who are already medically vulnerable. Also, our experience as health workers mirrors those of health workers elsewhere who faced disasters, such as nurses after Superstorm Sandy. And there's been some literature on this. Next slide. So the residents with whom I work are a small fraction of the more than 167,000 trainee physicians in the United States. These are frontline workers who make sure people receive essential care. As climate change intensifies hurricanes and severe storms, health systems need to make sure they're also providing adequate support to this vulnerable population of workers. And if you'd like to learn more, I collaborated with residency program directors from Florida State University, University of South Florida, and my own institution to describe our experience with different hurricanes in Florida and our recommendations in the Journal of Graduate Medical Education, or you can also read my Narrative Matters piece. And back to Meg.
All right, thank you all. Those were great presentations. We have a lot of things to think about. Participants, you can put your Q&A in the box, but I'm going to kick us off. I want to pick up on a thread that Cecilia started during the first session that came across really strongly here, that the health effects of climate change can be really diffuse and really varied geographically. And that was very strong in your papers. But can any of you speak to the tension between kind of that regional variation and trying to prioritize climate policies on a broader scale? Any volunteers?
I can provide some additional commentary on it, although I don't know about fully formed solutions. But I do think that that's definitely something we saw reflected in our findings looking at CHNA content from hospitals, and that there was such a variance between how states were responding geographically across the US. While all of the CHNAs had relatively little climate content, the fact that there was a statistically significant difference between different regions of the US did just emphasize the fact that maybe certain geographic regions would be able to implement more stringent state level policies that would improve reporting and documentation in those areas. But there is also a need for some sort of policy action that brings all of these regions into the mix, because climate vulnerability certainly exists across the country.
My tiny addition there would be just that. So in our paper, we aren't looking across regional differences. We're looking at the nation as a whole of what is the population effect. So even at a population level, we are detecting.
Jeff, you're frozen again for us.
In aspect certainly matters, but really there are
Dara, did you want to chime in?
Yeah, I can add a little bit, at least from our project that looked at cold specifically. When you think about cold-related illness, you may think that there is a region specifically that is really impacted, and that was true. Colder regions did have higher baseline hospitalization rates, like the Midwest, for example. But in our paper, we found that cold-related illness isn't limited to just those areas. We saw increases across the country, and I think that ties into Dr. Silva's paper very well, that we saw increases in CRI hospitalization rates in the South, and her study found that that's not even climate-based questions are not considered in a lot of those CHNAs in the South. And so I think that just suggests that regions that are less accustomed to extreme cold may not have the infrastructure or level of preparedness needed. And from a health systems perspective, that means that adaptation strategies can't be limited to traditionally cold climates. That I think also ties in very well with Dr. Bauhoff's paper, where they discuss, higher level, broad policy level interventions we could and should think about, but also considering adaptation at the person level and not just the infrastructure itself.
I'll see if my internet will hold up for the 20 seconds. I just wanted to say that like our paper looks nationally. It's not looking at region-specific effects, and we still are seeing at a national average that there's increased utilization across the board for ED utilization. We look at all cause. We're not even looking at just heat-related illness. We see increases in all cause across the board for ED. We see it for some inpatient. So the regional aspect is certainly one that could be a place to start, but I would just like to chime in that it's across the nation.
Great, thank you. I wanted to ask Sebastian the next question. You spoke about kind of shifting to managing risk instead of responding to crisis. How do you think we can take the first steps in moving in that direction? Like where should we aim interventions to make that transition?
Yeah, great question. Thank you. And thanks to all the other presenters. I think it all ties together really nicely. I think, I think the important thing is really to take stock of what we're trying to accomplish here in terms of what elements of risk to manage. And maybe that differs a little bit across across different parts of the country and the globe, and then to see what existing tools we have that we can already deploy. This is not a separate agenda from general health systems improvement or sort of trying to achieve health policy goals. It's also not specific to, let's say, weather-related events or anything like this. This is really an all-hazards approach, stepping back from understanding that health systems don't only just deal with stability anymore, but have to deal with a lot of variability. And so I think this can really be applied anywhere. There's already a lot of existing space. We already heard, I think, in the presentations today, for example, the Joint Commission in the US, Medicaid waivers, other kind of things are available to do a lot of this risk management already. I think the sort of wrong message here, and the one that I hope I did not convey, is that this requires a fundamental sort of development of new tools and just sort of forgetting what we're focused on already. But there's really a lot of opportunity already to put this stuff into action, that we just need to put a bit together in sort of a more strategic and maybe comprehensive kind of way. So I think it's really broadly applicable depending where you are, and sort of the tools already available. We just have to put them to good use.
Great, thank you. Yeah, I think that was a theme in a lot of the papers in this issue, that we have existing tools that work. It's just about kind of scaling them. We have evidence. We have a few questions in the chat. So I was going to start with the first one that is for you, Aaron. This person asked, how are your findings applicable to other natural disasters caused by climate change? How can you set up the infrastructure for patients and providers that is location and risk specific?
It's interesting. I've actually partnered with people from other residency programs around the country to do conferences on this topic. And, hurricanes are somewhat predictable because we do know days in advance, but things like wildfires are not so necessarily so predictable. And then there's also things like, in Asheville, they did not expect the disaster that hit them. And I'm coming from the South, from a state that has minimal safety net, right? So, we already have a problem with our energy grid, our mental health support for people, things like, help with paying for rent, even, getting things like FEMA support. That takes a long time to get support. So I think that really to address this, you need improved access for everybody to mental health care. You need an improved energy grid. You need if you can't get electricity up, you need it up in the low income areas as well as the affluent areas. Definitely in Miami-Dade County, we always see after the storms, the affluent areas get their power on relatively quickly, and the low income areas, it can take weeks to get the power on. So I'm not sure if that answers the question, but I think we need a more robust safety net to help people cope with this. So
great, thank you. The next question from the chat is for Genevieve. Looking at community health needs assessments, this person says that there were climate impact questions when they participated in CHNAs, but they were treated as optional. And so for vulnerable populations, they didn't end up collecting the same data. And so they ask, how can we ensure equitable data collection in such important assessments like the CHNA, which help determine healthcare funding when there are these competing needs?
Yeah, that's certainly something that we touch on a bit more in the discussion section of the paper that we worked on. Of there are so many different health vulnerabilities that a CHNA must encompass and consider, and how are those prioritized, and which ones do make the top list of recommendations that go on to be incorporated into the community health improvement plans. And where we landed in our recommendations was really bolstering the IRS requirements to at least mandate and recommend consideration of climate health risks by using standardized climate health metrics. And then once that data is obtained along with all of the other community climate or community health risks, then input from community representatives and experts could be obtained to kind of help balance and prioritize which of these issues is the most pressing and making sure to incorporate an equity lens when making that prioritization. And I think sometimes these community health needs assessments are compiled exclusively by internal hospital staff, and it really varies from health system to health system. And incorporating some sort of community health representatives and bringing those voices into the room is also another way to really make sure that those impacts aren't overlooked and deprioritized when they should be incorporated.
Great. Yeah, I think some of the papers from session 2 touch on those partnerships that we can use as a model. I'm going to wrap up with one final question that is put to any of you. You're welcome to respond. It's kind of a comment question from the chat. Someone says, politicians respond to short-term problems but are less incented to respond to long-term risk. Do you have ideas about changing incentives? It's a big one.
I got some thoughts on that, if I may. I think the first thing I would say is maybe we can rephrase the problem rather than framing it as sort of a trade-off between what we already do, just to make clear that it's actually contributing to improvements in health systems performance. This is not an either or, but sort of investments in sort of, let's say in my case, risk management or adaptation is actually complementary to what we're trying to achieve. This is not sort of a separate agenda. It's the same stuff. We just need to keep in mind that we need to, consider these risks and sort of impacts in our health policies and planning that we already do. There's an existing toolkit that just needs maybe a little bit of extension. I think that already goes a long way. And then the second thing I would say, and oftentimes I think there's a very hard-nosed business case to be made. Put aside sort of the health issues. I think there's a strong economic argument to be made for investment and resilience and adaptation. So I take the point. I think this is an incentive problem, but I think part of it is a framing problem and how this arrives at policymakers and how they're presented with their choices there.
Fantastic. Does anyone else want to chime in with last words?
Can I say something else?
Sure.
I mean, it's great, yes, to make these arguments about the economic benefits, but I think politicians respond to what's going to get them elected. And if there is public pressure on them, if the public realizes this and they take action and they prioritize it as something when they're voting, and this goes not just for blue voters, but for voters all over this country, then politicians will take action. But I think, I'm very maybe I'm just really cynical. I think politicians act according to their own interest and their own electability. And we have to have public education about this and make people realize, have the public prioritize it.
Thank you. Yeah, I think we all have our work cut out for us. Unfortunately, we are out of time for question and answers. Thank you all so much for participating today. I'm going to hand it back to Dom to wrap us up.
Yeah, thank you, Meg. And really, Meg was the editor in charge of this issue. I want to thank her. I want to thank the entire staff of Health Affairs. Theme issues are really incredibly complex undertakings, and they play out over many months, and a lot goes on behind the scenes to produce the issue and the event. So I really thank the staff. Of course, I want to thank the authors who contributed papers, the reviewers who helped us review the papers, today's moderators and presenters. Some of the content in the issue we saw. There's a lot more in the issue, a lot more detail, a lot more content. It's very rich. Of course, I want to thank our funders, the Kresge Foundation, the Robert Wood Johnson Foundation, and our audience. Really, thank you all for joining us. Really appreciate the interest. Hope you will also join us for an upcoming event, Understanding ICHRA, that is Individual Coverage Health Reimbursement Arrangements. That's with Jason Levitas of the Urban Institute. That'll be May 13 from 1 to 1:30 p.m. Eastern Time. This event will be exclusive to Health Affairs Insider members. Today's event recording will be made available on our website, healthaffairs.org. So I hope if you weren't able to see everything and you're interested in more, I hope you'll see that. And again, I hope you'll read the issue. Again, thank you, everybody. Really wonderful presentations. Thanks for your interest. And we are adjourned. Thank you.